Good morning. I welcome you to the workshop on myelodysplastic syndromes and the treatment of low risk MDS patients from supportive care and early intervention towards targeted therapy. My name is Reinhard Stauder. I was hematologist at the Medical University Innsbruck for years, was responsible for the MDS program. Actually, I am a researcher at the private university UMIT, which is quite close to Innsbruck. This organization focuses on health technology assessment and on public health. Today we have 2 hours interrupted by a break of 15 minutes. It is a workshop, which means the organizers have motivated me to motivate you to be interactive, which means your questions, your contributions are essential, which means we also may interrupt the speakers if you have very important or relevant questions. We have 2 outstanding speakers today. Either you could give your questions by mobile phone, or at the end of the presentations you go to the microphone. Both approaches are highly appreciated. Moreover, I should monitor the time quite closely, and I think now we could proceed. The first presentation is by Eva Hellstrom-Lindberg. She's in the field for years. She's from Sweden, from Karolinska Institute. She has been in the field for years. You may know the Hellstrom score, which helps to predict the response to erythropoiesis-stimulating agents. She was president of the European Association of Hematology, and she is also quite active in the field of translational research. She will give a presentation on ESAs and on transfusion with focus on early interventions, which means when should we start therapy, which hemoglobin values are relevant for decision making. Eva, I ask you to start the presentation.
Thank you very much. Thank you, Reinhard. My voice is not the best. Had a cold for a long time now, so I may have to stop and drink some water, but let's hope for the best. I will try to be rather fast, because I really would like you to ask questions or comments or disagree, whatever. And you can shout. It's a bit dark, so I may not see it, but you just raise your voice if you want to. Okay, I have nothing to disclose. So this is what you see as a doctor of patients with low risk MDS. You see these lovely old people. This is a guy with MDS with ring sideroblast coming in every 14 days to get 2 blood packages. And we know from many, many studies that I will not show that if you have a transfusion dependency when you are diagnosed, your prognosis will be worse. This is an old slide summoned by Mario Cazzola, published now 20 years ago, but there have been many, many during the course of these years. But the problem is that we don't know why you have a reduced survival. And you can think of various, here are 3 potential explanations. It's actually so that the transfusion dependency reflects a worse MDS biology, leading to a more rapid leukemic transformation. Or it's so that just going around with chronic anemia leads to a more rapid death, in particular if you're old. It has been published several times that these individuals with transfusion need have a higher incidence of cardiovascular disease. Or it has to do with iron overload or toxicity. And most likely for many of these individuals, we have something that adds on from all these things. So how common is transfusion need in MDS? And here I use a lot of data from the Swedish register because we have an absolutely complete transfusion register from the blood bank. You can't get blood in Sweden without ending up in this register. So in the one of the first publications in 2018, we had 1,300 MDS patients, and 49% were transfusion dependent at diagnosis. At a later follow-up, it had decreased to 41%, most likely because we are now better at diagnosing MDS earlier. In the EU MDS register, also published some ways ago, the transfusion dependency incidence at diagnosis is 41%. That requires actually that you have follow-up, so it's a bit more tricky data. In the WPSS cohort that gave us that score almost 20 years ago, it was shown that transfusion dependency was a very strong, significant risk factor, but exact incidence was not given. This is a new study from the EU MDS register showing both transfusion dependency, yes or no, and then if you have a label plasma iron detectable. And in the best of these curves, you have neither, no label iron pool detectable and no transfusion need. And if you have both, you have the worst prognosis. So it does matter to be transfusion dependent. I think these data are quite remarkable. I pulled them out of the Swedish register a few days ago, and it's not a publication, it's a report. You can read it, but it's in Sweden. And if you look at patients who are transfusion dependent or not at diagnosis, and this reflects the Swedish cancer register, so we get around 98-99% of all MDS patients. And you can see the tremendous difference in survival between those being transfusion independent and dependent. And even more so, looking to the right, the relative survival, there you have an even larger difference. So it's not good to be transfusion dependent. We still don't know why. So then I know that you all have used or have read or both the IPSS-MOL risk score. It's nowadays it had turned into one of the best used risk scores internationally, and you know the characteristic curves. And when this register was actually created, anemia turned out to be the cytopenia with strongest influence on prognosis. But transfusion dependency at diagnosis was not a reported variable, because since this is from data from all over the world, this is not something that you record in all countries. And what we know from the IPSS-MOL, which may then come to the question, is it so that transfusion-dependent patients have worse form of MDS, is that comparing IPSS-R that we had before with the M, we know that IPSS-MOL shifts the risk to a higher risk compared to the IPSS-R, most often because you may have patients without blast increase and without very, very significant cytopenia, but with all these mutations that we know much more of today. So Maria Klenow in Stockholm, in my group, decided to make a study combining the Swedish cohort from the IPSS-MOL, which is something above 700 patients, and she combined that with the register, or the Swedish ScanDat register, where we have all the transfusions given. And she used the multi-state modeling, and she really wanted to say, if you combine transfusion state, information about that, and the IPSS-MOL, that was exactly the data that Elsa Bernard produced for us. What would you get then? Well, you will get a study. We had around 700-something patients with what you see here, with the IPS-MOL risk groups and the WHO subgroups. And here is the molecular characteristics. The yellow here is those with transfusion dependency, and the green one, those that were transfusion independent at diagnosis. And you can see from the molecular that it's not that much of a difference between these groups, perhaps a bit more dense in the transfusion-dependent groups. So, and this is then a Sankey diagram, and the blue ones here are those without transfusion dependency at diagnosis, and the yellow one those with transfusion dependency. And one important lesson from this, and these patients are then treated according to Swedish routines. We are very eager to give ESAs in the Nordic guidelines. For many years, we had the recommendation to give ESA treatment at start of symptomatic anemia, and we have never really required transfusion dependency. So as you can see, and these are 4 months interval, most of the events occur within the first year. Okay, and we, after looking at this, we came to the conclusion that transfusion state at 8 months, and that means that between month 4 and 8 you were either transfusion dependent or independent. So for these 4 months would actually was the best way of looking at transfusion. That would cover both response to ESA if that was given at diagnosis, or azacitidine if that was given at diagnosis. The other drugs available is not given to sort of a large enough proportion of the patients. And this is one of the data. So the green curve here is actually patients without, they are transfusion free from diagnosis. And then we also wanted to test what has been published every now and then, that patients with low transfusion need fare better than those with a high transfusion need. But in this study, there was no difference. So were you transfusion dependent, you had a clearly worse prognosis than if you had transfusion independency at start of treatment. There were no difference between high and low TBD. These are then the curves. The left curve is patients being transfusion independent from 0 to 4 months. The middle curve being transfusion independent between 4 and 8 months, and in the last curve between 8 and 12 months. The top curve is lower risk IPS. There are 3 lower risk groups according to IPSS-MOL without transfusion need between 4 and 8 months. The lower one is the IPSS-MOL higher 3 risk groups with transfusion need, and the 2 in the middle actually are lower risk with transfusion need and high risk without transfusion need. So people actually reaching transfusion independence with the treatment you have given them. This was actually valid even if you looked at specific subgroups. The left curve is actually what I showed you in the previous slide, all patients. Then in the middle, SF3B1 mutated patients, the majority of them good risk MDS RS. And in the last curve, you see TP53 mutated patients. So it seems to be important for the higher risk groups and for the lower risk groups. And then this is then the multi-state prognostic model. So if you actually added on data on survival, being transfusion independent were an independent, very clearly significant factor. I don't know if I have something to point me, but I think you can see what I mean. That is the top curve, while if you looked for AML transformation, the difference was not as important. So it seems to be something that is not mainly the risk for AML transformation, but some of the other factors, and definitely not the IPSS-MOL. So I think this is very important. Transfusion dependency teaches us something that we cannot gain from what we have today. So what can it be then? Because when we looked, and we have been studying MDS RS with SF3B1 mutations for many years, and we know because we have looked at patients at loss of response and prior to treatment and so forth, and it's not clonal evolution. They don't get more mutations. They don't get additional mutations. But this is quite interesting. This is a study on HSPC. From the blue ones are patients with MDS-RS paddling on with a stable hemoglobin level. Even if it's low, it's stable without any treatment. The red ones are patients who have become refractory to ESA after some years, and the green ones are actually patients responding to ESA. And you can see the difference, apart from LMPPs, which is, I would put that aside, all the others clearly show that the ability to maintain a hemoglobin is actually reflecting the variant allele frequency in the early stem and progenitor cell compartments. And the difference is quite significant. So it seems like being transfusion dependent or in the need for treatment reflects that most of the stem cells in the bone marrow actually have become mutated. This is something that we are looking into very eagerly now. Now I will turn to another study from the EU MDS, shared by Hege Garelius, I think is in the audience there. Yes, you're very dark over there. And this is the first study. I will not be too lengthy on this, but what Hege showed, that if you're untransfused and respond to treatment, this is the likelihood of receiving your first transfusion from the starting point. And you can see here that the best thing is to be starting ESA treatment before you become transfusion dependent. Then you will sort of have the longest untransfused period. If you don't respond, your curve to transfusion is more rapid, and if you are responding, even if you have been transfused, it's somewhere in between. Yeah, they like that slide, Hege. So now something has wandered. I think I need some kind of, because this, no, sorry. Okay, so here is then the very recently published study that we did with many more patients and a longer follow-up. And what we did with the propensity score matching, which is that you score it to have risk factors and country of origin and so forth accounted for. So if you look at ESA untreated and ESA treated patients, irrespective of the reason for why they are treated, we clearly show in this large collaborative study that ESA prolongs survival. So here the median survival is 44.9 months, and that is 10 months more than in the no ESA group. And the no ESA is mainly because ESA is not possible to give in some countries, it's not reimbursed. Sometimes you have to be transfusion dependent to get it reimbursed. There are many reasons, but I would like to say this is sort of a political randomization. When we then looked at overall survival and transfusion status, the blue one are those being untransfused before start. The yellow one, they have received a maximum of 4 units of blood, and the red ones are those receiving more than that. And you can see that already this little, being just started on transfusion therapy, makes your survival decrease. So I think this shows very clearly that it's better to start ESA earlier, and this same goes for transfusion. What we also showed in this study, and here's again the Sankey diagram, where the top curve is no ESA, no transfusions. The lower one is no ESA and transfusions, and the other groups are between. But what we wanted to show in this slide is also how does quality of life develop over time. And as you can see, the two curves, the two upper curves, the yellow and the blue, if you don't receive red cell transfusions, your quality of life maintains over the months. And this is a total of six-month cycle, that is 3 years. So it is actually good to avoid transfusions. So to summarize ESA, this is in the Nordic guidelines, it's in the European guidelines, and it will also be there in the international guidelines that we are working with. If possible, start before onset of transfusion need or as soon as possible. And starting doses, I will not go into, it's not the focus of today. Maximum doses, depending where you are, 60 to 80,000 units per week. Usually, if you start early, a response can usually be evaluated within 4 months. And then so that will sort of give you the survival advantage. We can add GCSF if no or lost response, and response duration varies in studies depending on the patient material, but median response time, if started before transfusion need, is around 3 years, and then you sort of postpone a lot of problems for a long time. Lost or no response is usually not associated with disease progression or clonal evolution, but with clonal expansion of the clones that you had from the beginning. Okay, I will now be very quick on this because they will come later during this week, but we know that lenalidomide have an indication in lower risk MDS with isolated del(5q) in Europe, and I think in lower risk MDS in general in the US, with transfusion need, because that was how the studies was designed. They should not have TP53 mutations, as you can see on these curves. I think this is a very interesting study recently published last year by Elena Krisa and a Harmony team, that if you...
Eva,
yes?
I think this topic will be
then I just,
addressed by Amy in the next
absolutely.
presentation.
I just would like to say, luspatercept, you have to have transfusion dependency before starting it and even going into the study. EMA license is only for RS. Imetelstat, the same there. The studies were actually made in patients with transfusion dependency. So this is then the acknowledgement. I will then revert to my conclusions. This is the team I would like to acknowledge for this. But conclusions then and remaining questions. I think we can confidently show that freedom from transfusion, primary or secondary after treatment, is an IPSS-small independent favorable factor. And it seems, at least in our hands, that 8 months from diagnosis is the best time for evaluation. The EU MDS registry shows improved survival and qual in untransfused patients, with or without ESA. All data that we have today supports initiating ESA treatment before onset of a transfusion dependency, which is recommended by European and upcoming international guidelines. However, all studies of pro-erythroid drugs in low-risk MDS employ transfusion dependency as entry criteria. And very few of these studies are designed to evaluate survival. And FDA, to the least intense extent, EMA, but very often national authorities require survival benefit to approve and reimburse a new drug, which is kind of a circle of negative evidence, because no studies have actually been shown to show that. But I think we have now 2 studies of big data sets showing that being transfusion independent is very important. And new drugs, as well as ESA, are presently not available or reimbursed in many countries. For example, in Sweden, which most people think is a fairly well-off country, we can't give luspatercept because they require survival evidence. So this is my last slide. What are we treating and how? So this is a patient, starts with a hemoglobin, perhaps not normal, but still maintaining. So, and after X years or months, but usually after years, if it's a lower risk, the hemoglobin starts to taper. I think this is what we should do. We should then start with drug 1. Today, ESA, I would say, because today it's about 1/10 of the cost of many other drugs. That makes the patient respond if you avoid transfusions, and then it paddles on for a while, and when the patient becomes refractory, we give drug 2. In this example, we don't have drug 3, but perhaps we have that, and we can continue. We could just push the time for transfusion need, which you see there to the right, as long as possible. And you have to decide about the individual transfusion trigger for the individual patient. That varies a lot. And my suggestions for studies and authorities in low-risk MDS is that they should use except pre-transfusion dependent symptomatic anemia as entry criteria. And they should use durable transfusion independency as a major endpoint. I would suggest a minimum of 6 months, perhaps even 12. And studies should include continuous assessment of variant allele frequencies and potential emergence of new clones. So that was my talk. Yeah, and I think we have time for questions.
Thank you very much. Maybe ask the technical assistants to turn on the light in the audience. We can't see you. One question from the audience: how do you combine ESA and GCSF in practice, both on the same day? I mean, it's in the suggestions now for years, but how is it realized in daily life?
Yeah, so I find it quite easy. So we start with ESA once a week. At least we do that in Sweden.
Could you go to the microphone?
Okay, so we start with ESA once a week, Mondays or whatever. I mean, in Europe we always self-inject. I know it's different in the US, but a nurse in the district nurse teaches the patient. It takes about 1 or 2 occasions. Usually then we start, if they don't respond, we increase to 2 days a week. So we give the whole weekly dose divided on two occasions. If they need GCSF, and that is if they don't have inflammatory symptoms, in particular if they have, for example, SF3B1 mutation, we add it the same day. So then they take a little shot of GCSF the same days. And we sort of usually tailor it to the effect so that is how we do it, and then we continue for as long as it helps.
And do you study with 30 millions twice a week with GCSF?
Yeah, depending on, I mean, something like that. But you have to. We are so used to it for the last 20-25 years. So I think people just try on, and then they find something that helps the patient. Yes.
Hi, Gregor Schleele from Basel, Switzerland. You showed the recent data from the EU MDS registry from 2025.
Yeah.
That ESA-treated patient had a better overall survival, and it was a propensity score matching, if I understood correctly.
I would say the correct thing is to say ESA exposed. We haven't really, we didn't even check if they responded. We thought this was a more ESA exposed, yes.
Was the endogenous EPO included in this propensity score matching?
Yeah.
Or how do you know that it's not just a better prognosis guys who have not been treated?
Yeah. So the thing is, it's a very, very good question. And but the thing was that in the EU MDS register, only 50% of patients had actually baseline EPO levels measured. And it's not really a routine in all countries. When we looked in the small cohort we had, it worked out fine, but we couldn't use it in the model because it was missing in 50% of the patients. I don't think that was the reason, actually.
So you really think it's the treatment itself that...
Exposure, yes.
Or the exposure that makes the better prognosis?
Yes. Because these patients also had a significantly longer time to first transfusion. So that we showed in the first study. This study was focused on survival and quality of life.
We have a very sophistical question. Eva, you have shown that transfusion dependency causes worse outcome of patients. That might be a reflection of the biology, that might be the iron overload, that might be the deterioration of pre-existing comorbidities. What's about the reversing of the transfusion dependency? Does that
you mean if they have
improve the survival and the outcome?
So the question is if an intensified transfusion need, if you get it more often, that would worsen prognosis. The thing is that we looked at that in Maria Creno's study, and we couldn't find that. I think in my hands, if a person starts to be transfusion dependent and you don't have a drug, even if they start every 6 weeks or 4 weeks, it takes them less than half a year to be more regularly transfusion dependent. So I don't think that is an effect that actually influences the prognosis so much.
But I mean, if you improve the transfusion dependence, do you improve the survival or the outcome of the patients? So
Not in any, not
the other
in,
way around.
As long as they are still transfusion dependent, I don't think we have seen anything. This is very, very difficult because then you have to have a very valid measurement of transfusion need. So I've never seen it in any of our EPO GCSF studies. I don't think so. I think this improvement is, sometimes the patients would like to do it and then you can let them, but I don't think it really matters.
I think last question, yes.
Thank you. My name is Janan Alhan. I'm a hematologist at Amsterdam UMC. And as you probably know, our colleagues in the United States do not prescribe GCSF to relieve anemia in patients with MDS. And also the trials, so the luspatercept trials, they do not use GCSF combined with EPO. So I'm kind of struggling to really apply, to look at that data and make sense of, well, for my clinical practice. But I think for future clinical trials with ESAs, or similar agents as luspatercept, how are we going to bridge the gap?
Yeah, that's a very good point. I mean, in Sweden, it's an easy question because I'm not allowed to give luspatercept because they didn't think I think it's a very good drug. So this is just the authorities. And then ESA is about 1/10 of the cost of luspatercept. To start with ESA is probably a wise thing, I think. To add on for us, adding on GCSF, it doesn't help always, but for example, for SF3B1, it's fairly effective. So for us in Sweden, since we can't give luspatercept, this is the logical step. If I had luspatercept, I would really like to make a study where you sort of try to prevent the onset of transfusion need. And I don't have a good answer because in Europe it's so patchy what you can give and not. But I think one should work with the authorities. Yep, okay, good.
Okay, thank you very much. Also, thank you to the audience for the
Good questions.
lively discussion. Now we continue with Amy DeZern. She will talk about lenalidomide in MDS, non-del(5q) and del(5q), including early treatment and the stop of treatment. Amy is from the Johns Hopkins University in the United States. Her research activities consist of designing and conducting clinical trials that test investigational new therapies and approaches in the treatment of bone marrow failure. So her expertise lies in aplastic anemia and myelodysplastic syndrome. She's chair of the working group 3 for the international MDS guidelines. Amy is working on the MDS guidelines for the NCCN and was in 2023 education chair for malignant hematology for the ASH. So we highly appreciate now her to give a presentation.
Thanks so much. It's my pleasure to be here, and I'm one of those colleagues from the US, and I'm very grateful for the invitation. And it's fun to have some new data to talk about in lenalidomide. I will candidly say I haven't made new slides for lenalidomide in quite some time, so hopefully this will be fun. These are my disclosures. So today we're going to talk about that newer data, and some of it's on early treatment and the potential for cessation when you have disease control. And I think some of these pearls, which hopefully we'll have a little bit of discussion back and forth towards the end, is these may be relevant to deletion 5q, where we classically think about the use of lenalidomide, and maybe in the non-del 5q setting as well. So I think my colleague Eva has really done a nice job of talking about anemia. We all know how important it is and how detrimental it is for cardiovascular morbidity and transfusional iron overload, so I won't belabor this. In lenalidomide itself, when we see these large flow charts for where it falls into the lower risk paradigm, it usually comes right about where the red arrow is. And in the United States, it's actually not specifically restricted anywhere for low-risk disease or for deletion 5q or non-del 5q. Certainly there are labels and there are suggestions, but it's interesting to think about how we might be using it differently going forward. We actually learned how it worked after it was approved, and I love the story of ribosomopathies and ineffective erythropoiesis, and I think there may be some real bench to bedside, circle back for the translation from the two studies that I'm going to show you, and we'll talk about those for future directions. We know it has selective activity in del 5q, and that's where most of my focus will be today for the newer publications that have come out. These are the studies that have been some 20 years old publications, or just 15, but we know this is a drug that has a lot of potential to ameliorate that dangerous anemia in our deletion 5q and to a lesser degree the non-del 5q patients. We are not including this group of patients in some of the newer trials. We had a question about luspatercept. I think in the second half of this workshop, you're going to hear more about imetelstat. And these patients were sometimes excluded, and so that's why this data needs to take on a new thought process in the new era. We've known for a long time from the early publication what we can expect when somebody is transfusion dependent with the older IPSS low-risk deletion 5q disease in terms of erythroid response, the increase in hemoglobin at the time of that response, and then cytogenetic remission. And it's been known for quite some time that it also could be seen in non-del 5q. And so let's talk about this newer data. And this is a paper by Maria Diaz Campolello that was presented at ASH a few years coming, and really has only been out not quite a year from the phase 3 Centra-Rev trial. And so this was a phase 3 double-blind randomized placebo-controlled study. It was multi-center, predominantly conducted in Spain. And this is different than those studies that I flew through somewhat efficiently that you know from older times in deletion 5q. This used lenalidomide 5 milligrams a day on days 1 through 28 for a 28-day cycle, but in patients who were not yet transfusion dependent. So asking part of that question is, are we changing the natural history in a different way, or maybe it is in combination or in parallel to some of the things that Eva just taught us about ESAs. And it was compared to a placebo with a pretty lengthy follow-up of 108 weeks. I find the endpoints of this to be very thoughtful, and Eva talked about some endpoints that we might think about going forward, and this is the type of study that was designed in a very thoughtful way. So for those not receiving transfusions yet, but were known to have anemia from low-risk MDS that had a deletion 5q, can we push off that period of transfusion dependence? And certainly comparing it to observation and monitoring is relevant at the bedside. There are a lot of useful secondary objectives, as you can see here as well, and we'll get into this data. These are some of the final results from the clinical trial that were taken from the paper. The active treatment phase was now 5 years ago. We have pretty comparable data on efficacy and safety, and here's the actual reference that I showed you the title page of. So these patients are similar to some that you may see in your clinics. It's not a huge study, only about 60 patients, but very comparable between the len treated group with the placebo. And there we go. So you can see here, I always put lenalidomide in purple and placebo in orange for your reference going forward. And the median hemoglobin at the time of baseline, you can see here it was very similar between the two groups. The platelets were not as high as you might see in some del(5q) populations, but there were not increased blasts. And the time from diagnosis to enrollment on the trial, I found to be humblingly fast, which is always nice for trial accrual. In terms of the patient disposition, you can see that patients could stay on for quite some time. I mentioned that longer follow-up of 108 weeks, and you can see that the Len-treated patients, which are about 2 to 1, were longer than the placebo. There was successful treatment completion in about half of the Len group and about a third of the placebo group. And you can see the reasons for discontinuation here, which I always spend a lot of time looking at, even in a small study. Non-compliance was not a problem. Physician decision usually drives a lot of it. Sometimes we have a preconceived notion about this a priori. And it wasn't a huge issue of patient request, and I think that speaks to what we know about the tolerance of the drug. And now I think many of you have seen this curve as we have played it out over the past 5 years in other oral presentations that Dr. Diaz-Campo gave, that transfusion dependence could be pushed off when you use lenalidomide early prior to the necessity of transfusions compared to placebo, and there's quite a separation in those curves, as you can see. Some of the more interesting data to me gets into the erythroid response and the cytogenetic response, because we're in a newer era with all the IPSS molecular that you heard a little bit about and we'll hear more about in the plenaries tomorrow and Friday. We now care about mutations we've always cared about karyotype, and we're realizing in lower risk disease we want to think about how we change the natural history. That's one reason to intervene early. And then here, as you can see down here, cytogenetic response was seen in those that were treated more than those who received placebo, which probably surprises no one, but I think as we counsel our patients, that's something to really think about how it might be meaningful to them. I won't spend much time on the tolerance. You have all used this drug, and there was really no difference in the safety profile than what we've seen. And some people might say if you're intervening early, perhaps you should have a different threshold for hematologic adverse events. I'm not totally sure I agree with that necessarily. It depends on what you're trying to do at the end of the day. But again, these numbers were not disturbing, not particularly high, and other than neutropenia with lenalidomide, which we know is an issue more than placebo, nothing was too surprising here. Something that always has to be considered in a lower risk disease, even though we know there is a rate of evolution in del(5q) disease to AML, is would early treatment affect that in an adverse way? And according to this, no. These curves do overlap, as you can see, and the overall survival wasn't that much longer than, and remember, this was not the primary endpoint of this study, but something to think about, that you're not harming people with early intervention, which I think had candidly been an early concern when this trial started being presented elsewhere. And something I was very worried about was clonal evolution. We have a game in the United States that we call whack-a-mole. You play it in an arcade with your children and something pops up, you hit it down with a mallet and something else pops up. So maybe if you decrease the deletion 5q, you're going to cause something else to come out and be problematic. And that was something that was mentioned in many questions and things when this paper was being presented. The most frequently mutated genes, perhaps unsurprising to anybody, were SF3B1 and TP53. And they were pretty similar frequencies in both the Len-treated patients and the placebo. And there were median variant allele frequencies checked, and this really showed that the Len-treated patients had the ability to decrease the VAF. Here, it was from 9% to just a little under 2%. I think that is perhaps not overtly clinically significant in changing the natural history in terms of survival as we saw, but it clearly shows that we're hitting the clone and doing something. And I think that was helpful to people, specifically to the concern of the increased TP53 evolution. There have always been different management approaches. If you knew a deletion 5q patient had the presence of a TP53 mutation, I think many of us follow them a little bit more actively, and also perhaps are earlier to switch away, but this study would suggest that even in the presence of a TP53 mutation, you could have a response to lenalidomide in terms of erythroid response and cytogenetic response, and the clone size, interestingly enough, decreased in 5 of the 6 patients that had it. Now, a third of those patients ultimately did die. It's only 6 patients, so let's be honest. 2 patients did ultimately have AML, but you can see it's quite far out, so more than 5 years in both patients. Did the lenalidomide cause TP53? Back to my whack-a-mole analogy, and it's not so clear that that was the case. So everyone feels, I think, quite reassured about early intervention with this. So hopefully we can talk more in the question period just about some of these things. But just summarizing this nice paper quickly, we know that early intervention with a modest dose at 5 milligrams can prolong the time to transfusion dependency. We get erythroid responses in a very similar proportion that we see in the transfusion-dependent data from the earlier studies that brought it to approval. Cytogenetic response is really meaningful and important, and that somewhat surprises me that it doesn't extend the overall survival, but it's good, and we're not seeing a promotion of clonal evolution, even in some of the higher risk molecular subsets. So certainly there's always going to be questions remaining when the study's sample size is relatively small, and I do find the follow-up to this study to be excellent, but longer-term follow-up is always better. Are we going to see more clonal escape just the longer you do it? That's something that I think our myeloma colleagues have possibly learned. We'll have to see. And will ultimately there be a separation of the overall survival curve if we look larger and larger? I think you'll start to see recapitulation of this data in real-world data sets. And I like to think about this as a disease-modifying early intervention in disease that we've historically monitored. And we'll also hear a lot about clonal cytopenias of undetermined significance and when and how to intervene early in that lower risk entity as well. And then certainly the 2 questions that bother me as a clinician and I think a patient might ask is, if you do this really early, what do you have left over? And in the MDS field where we have fewer drugs than we wish we did, this is always, I think, a fair consideration. And then maybe the American question, you'll forgive me, but if 5 is good, is 10 better? I don't know, but all things fun to think about, and I'll be interested to hear your thoughts during the question period. So then I'll move to a second paper about discontinuation. Here we're talking about starting early, and this is on the back end. So Dr. Crisa and Dr. Santini led this study, the Harmony Alliance, looking for if you can stop a drug after one of these deletion 5q patients becomes transfusion independent. And I find this a common question for patients. Perhaps they're having a neuropathy or thyroid derangements or just don't want the financial toxicity or the long-term use of a chemotherapy pill. So they had about 118 patients. You can see the breakdown of the baseline characteristics here. Again, very similar to what we saw just in general for this population in Alan List's early study and even in the early intervention study that we just reviewed. In terms of these data, there's nothing so different here. In the red cell transfusion burden that we have been thinking about, high transfusion burden versus low transfusion burden, this was a fairly heavily transfused group. As you can see, that nearly 100 of the patients were receiving more than 4 units in the 8 weeks prior to the initiation of the lenalidomide for the traditional indication. And then these are the baseline characteristics once they were on lenalidomide. And so the best response was transfusion independence at the top there. You can see, again, no real difference in toxicity. And about a third of the patients had had a dose reduction from 10 to 5 for cytopenias or other reasons. And the median number of lenalidomide cycles was 12, but you can see there's quite a range there in the last row. And so at the time of discontinuation, the patients, again, were a wide range of ages, 33 to 97. The neutrophils didn't necessarily seem to be driving the discontinuation, though some of those numbers in that range are low. The hemoglobin was pretty robust at cessation, as were the platelets, and nobody stopped for increased blasts, which again is useful to know. In terms of cytogenetic response, 95 of the patients were eligible for this assessment, and about 45, as I mentioned, had it. And you'll just hold on to that number when we think about who maybe was eligible for stopping or otherwise. And the reason for discontinuation is listed there. Intolerance was a pretty high number, and that's, I think, why people want to think about it, even if it achieved the metric of transfusion dependence. If a physician thought they had maxed out their hemoglobin on the drug, it wasn't as much a patient decision in this particular series. So here's the duration of red cell transfusion independence after lenalidomide discontinuation. Probably this is the real money slide, if you will. And you can see that they maintained this duration of transfusion independence if they had already had more cycles, greater than 12 compared to less than 12. And then, again, not surprisingly, probably, if they had a lower transfusion burden in the red at the time of discontinuation, which is what got them on it in the first place, they were able to sustain that transfusion independent for longer than if, remember, those high transfusion burden patients that I pointed out in the lower row of the table. So what are some of the prognostic factors? Now, that may not be the best way to characterize these really, but what are the features that make us think about somebody who should not necessarily stop, even though they have red cell transfusion independence? So these came from the multivariate analysis: age, that high transfusion burden before they started, the lenalidomide for more than 12 cycles, and then a higher hemoglobin level at the time of lenalidomide discontinuation. So nothing so striking here, though there is some statistical significance, but I think all reasons to think about whether or not we should do it for a patient or not. The event-free survival after lenalidomide discontinuation, and events could be obviously transfusion dependence again, or starting another therapy, be that returning to lenalidomide or another MDS-directed therapy. And again, overall, it is sustainable for a pretty good length of time, where if you were toxicity conscious, cost conscious, or just active treatment conscious, you could maybe go for a period of time, about 4 years at the median, without having an event for this whole cohort. Again, a little less if you did not get as much under your belt therapeutically by the time you stopped. So that 1 year may be something to think about. And during the study follow-up, there were almost 20% of the cohort that progressed to higher risk disease. Naturally, that was an event that necessitated more MDS-directed therapy. And there certainly were those who had AML and died. The causes of death were not all MDS-related, but again, this was a cohort that was somewhat ill, if you think about it this way. 20% progressing, and maybe the lenalidomide discontinuation didn't help that, but it's hard to make that association. And then what about the molecular outcomes? Because I think patients, and we as their providers, do worry about that. There was only molecular data available for about 30 patients, and 37% of the cohort had mutations detected. I find the combination of deletion 5q and SF3B1 to sometimes be more adverse, and that was the largest mutation that was seen. There were some TET2, DNMT3A, and a smattering of others, as you can see. The presence of TP53 was known, presence or absence, in 82 of the cases, and you can see the positivity rate there, and similar to the other study, actually, in terms of percentage. And this group also concluded that TP53 mutations did not impact overall survival or AML transformation in this cohort, and didn't seem to have driven the discontinuation early of lenalidomide. So I purposely left some time for questions, and this is an even newer publication than the prior phase 3 trial, but I think it's fun to summarize this and what we know with their follow-up at 48 months. Cessation of lenalidomide in a del(5q) patient when they're transfusion independent is completely feasible. The median transfusion independence time was 56 months, and 70% of the patients who were treated for more than 12 cycles, which is almost more than a year, were still red cell transfusion independent at 5 years. I think additional questions that I hope will prompt some comments by you, similar to the first study, is we still need longer-term follow-up, and we keep talking about this clonal escape, and I think we'll continue to focus on TP53 just to make sure. I think clinically, there might be an argument for repeating the bone marrow in those who are going, well, you won't know, but when you've repeated, if they have a cytogenetic response, maybe this will drive things a little bit sooner. And do these data suggest an intermittent administration to avoid toxicity? I think we always worry about that, and we can learn from our CML colleagues a little bit about how they stop TKIs and some of that off and on. But again, something to think about, and it is nice to have newer data in the lenalidomide space. So with that, it's a highly relevant drug, and we knew that, but it's fun to have new data in 2025. We're still learning about when to intervene and how we might predict response with genetics, and then maybe indefinite therapy is not always required. So we're trying to improve quality of life, both at the front and the back end for these patients, and ultimately we need to figure out how to improve survival, which remains really important for patients on lenalidomide and of course all MDS patients as well. So I'm grateful to you for being here and my colleagues whose work I presented, and I'm more than happy to take questions. Thank you.
Thank you very much. Please, let's have more light in the audience. Yes?
I have a question.
Yes. Eva, please.
Yeah, but I don't need to start. So thank you, Amy. Fantastic. I mean, it's fantastic when things stretch out over 20 years or even more. I have a question. I would like to describe briefly a patient that came to me 2.5 years ago. And she was a very young del(5q). She had been around in Europe and ended up in Sweden. And born in 1979. So at that came.
As was I.
Okay, so think about yourself. And she came highly anemic, and she came from Switzerland, I don't know really, but she was actually very much transfusion dependent. She had a very, very high ferritin level because she had been anemic for a long time. And since she was so young, and since we are a bit more afraid of TP53 mutations, I took a bone marrow, even took the bone marrow to a lab and sorted out CD34, and I sent them for NGS sequencing with a VAF cutoff of approximately 2, when you don't know what you're looking for. And she responded beautifully on Len, and after 1 year she stopped because she didn't want to have drugs necessarily. And she's still responding after 1 year, but then I took and the bone marrow I took when she stopped after 1 year was also perfectly normal. Then I took a new bone marrow, and now the incidence of del(5q) metaphases had increased a little bit, and when I check a new NGS, she has 3 independent p53 clones. So what would you do?
Well, that worries me. I think that case brings up a number of wonderful points. But the first is it is so useful that you have a marrow at the time of best response, but
Yes.
that you have one later as well.
Yeah.
And I think that is a patient in whom I would feel exceptionally anxious about. Probably we felt anxious to begin with because of her youth at the time of presentation, but I am a transplanter, and so somebody with that many mutations,
I agree.
that's what I would do. And that is what I tell these patients from the beginning. I know their baseline. I marrow when they're doing well, but I'm rapid to get to transplant because those are the TP53 that I've had long-term durable success in del(5q).
I think that's important. That if you meet a person or patient who would like to live for 30 or 40 years, this is not a disease that so often allow you to do that.
Agreed.
Comments from the audience? Yes.
Can you comment, it wasn't your talk, but what do you do when people fail lenalidomide with del(5q)?
The
So it's a
question
great-
is how to deal with persons who fail on lenalidomide with del(5q? From Stephen Neimer.
And I think it's a good question and sort of ties in Eva's clinical anecdote as well. I will say I do not HLA type at the beginning of a deletion 5q start. But in somebody who starts to dwindle, I HLA type then, But I usually use azacitidine, which is my HMA of choice most of the time, as a bridge to transplant when their response is waning, usually because I need that lead time. And there's some nice data from the Moffitt group about sequencing, and you can really get a response in a similar percentage of deletion 5q patients refractory to lenalidomide as you can with all comers with HMA.
Okay, thank you very much. I think, one last
Thanks.
fast question and fast answer, please.
MDS del 5q low EPO level. Do you start with ESA or with lenalidomide?
It's a fabulous question, and I have a super open conversation with the patient that I do not believe ESAs are wrong there, and we have to decide balance of toxicity and where we want to spend our time. But I am not uncomfortable with ESA to lenalidomide, though most people using this inter-rev, especially in the United States, would still start with len.
Okay, thank you very much, Amy. Now we close the first part of this workshop. I think we will have a break of 15 minutes, and then we will continue with luspatercept and imetelstat by Valeria Santini, and Moshe Mittelman in the end will give a review on treatment guidelines, and he will give a summary. Thank you very much to the audience and to the speakers.